Good evening, everyone, and welcome to today's webcast, Ask a Doc. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified. Number 1, accelerate discovery to cure psoriatic disease. Number 2, improve health outcomes. And number 3, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis to help manage your disease and to find others who understand what it means to live with psoriatic disease. You can help accelerate efforts towards a cure and greater understanding of psoriatic disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry for psoriasis patients in the U.S. The registry, which involves a network of dermatology clinics, collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments and better understand conditions that are related to psoriasis, as well as explore the history of the disease. You can also share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientists. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, you can visit the websites listed on this screen after tonight's presentation. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support system center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment options, navigate insurance issues, access our one-to-one program, and more. You can contact them at the email or phone number listed at the bottom of the slide. And to achieve Foundation goals, as mentioned, please support our mission through donations or by participating in local Team NPF events near you. Now I'd like to introduce our speaker, Dr. Abby Van Voorhees from the Eastern Virginia Medical School. As a professor and chair of dermatology, Dr. Van Voorhees specializes in caring for patients with psoriasis and eczema. She is actively involved in clinical research, particularly in issues related to the treatment of psoriasis. Prior to joining EVMS in 2015, Dr. Van Voorhees was the director of psoriasis services and phototherapy units at the University of Pennsylvania. Dr. Van Voorhees has published numerous peer-reviewed articles and has co-authored 3 books. Currently, Dr. Van Voorhees is medical editor of Dermatology World, the official magazine of the American Academy of Dermatology. She is also the first female chair of the National Psoriasis Foundation Medical Board and has been a member of their board since 2007. Welcome, Dr. Van Voorhees.
Thank you.
Great. So our Ask a Doc webcasts are dedicated completely to questions you have for Dr. Van Voorhees. We will split up tonight's questions into 3 main topics: disease and research, treatment, and lifestyle, which includes diet-related questions. You can enter your topic-specific questions by typing into the questions pane of the control panel. We will attempt to address as many as possible in the time allowed. All right, so let's get started with our first question. All right, on the topic of disease and research, could you talk a little bit about psoriasis of the mucosa? I have an issue with gums, outer edges of my eye, and labia.
So probably less is talked about psoriasis of the mucosa than any other area. We certainly speak about psoriasis of the labia, of the vagina, on the penis, and around the rectum. In fact, we call that a specific kind of psoriasis. We call that something called intertriginous psoriasis. The other name for that is inverse psoriasis. But psoriasis of the nasal passageways is something that we don't usually think about. I think often these areas are areas that, just as a result of where they're located, they're often damp. Sometimes they're sweaty, for example, in the groin, that's a very common area for sweat to accumulate. And so the skin often stays damp and irritated, and then and that triggers, I believe, and I think most of us believe, that triggers psoriasis in this area. So it's a catch-22 because, of course, you can't move the skin out of that area. It's hard not for the area to be occluded, but it does often make it quite challenging to treat that area of psoriasis. And I think, quite directly, sometimes it's an area that doctors are a little less comfortable talking about with you as the patient. So they may not ask you, and you may feel just as sheepish mentioning it. But I do want you to know very clearly that it's an area that can be quite effectively treated. And therefore, if you do have psoriasis in these kind of locations, you should definitely bring it to your doctor's attention so that, they can explain to you, number one, how to treat it. And I think equally important, how to protect the skin so it's not as much of an issue, to kind of break that cycle of the environment kind of triggering even more psoriasis. So I think it's a two-part kind of approach that's needed. But I think the first step is just bringing it up to the person who's caring for you, so that way they can address it.
Great, thanks so much. Next question here. I've been suffering from psoriasis for the last 5 years, and it's been spreading over my body. Is there any way to stop the spreading of psoriasis to other parts of my body?
Yeah, psoriasis is not contagious. So, it's not like, say, poison ivy, where if you get poison ivy on your hands and then you touch your leg, you could spread poison ivy. Psoriasis is really is a genetic disease. And exactly why it shows up in the locations it shows up is somewhat mysterious. Sometimes we know. For example, psoriasis can occur in response to trauma. Either trauma intentionally, for example, the most classic example is somebody might have surgery, and in the surgical scar, they'll develop psoriasis as a consequence of the trauma of the procedure. Other times it's more vague, just from scratching the skin, for example. Sometimes psoriasis will occur. So when the psoriasis occurs as a result of trauma, that can cause the disease to seem like it's spreading, because you may have psoriasis, for example, on your knees, and if you're spending a lot of time scratching your elbows, you can have psoriasis develop in that location. So certainly, avoiding trauma when that's possible is a good approach. But otherwise, we don't really understand what causes that genetic disease to turn on, and very specifically why it occurs in very unique spots. I think it's always, when I teach medical students, they're always surprised to see the very sharp outline of a psoriasis spot. So why it ends that abruptly, and 1 inch over the skin looks so normal, and 1 inch the other way the skin looks so inflamed. We just don't understand. And then you could get another spot 2 inches away, and why it starts all over again. So I don't think we understand what causes psoriasis to occur in these different places. But I can say, unless you're repetitively traumatizing an area, then you're not doing anything to cause it to spread. This is just part of the disease's march, if you will. So this is a disease of systemic inflammation. So that inflammation is in your whole body. So that doesn't mean to say if you have one spot, your whole body will be covered tomorrow. But it means that, there is that risk that it could show up in other locations. That's inherently part of the disease.
Okay, thank you. Next question here. Can menopause or perimenopause cause psoriasis to start?
It's very interesting. There are two times when we most commonly see psoriasis start. So the first is in young people, people in their early 20s, late teens, that kind of age. The second most common time for people to develop psoriasis is in their 50s and early 60s. And now that doesn't mean that you can't develop psoriasis at other points. I personally have seen psoriasis in, infants who are just a few weeks old. And the oldest person I've ever personally diagnosed was somebody who was 91. I remember having that conversation with that woman and her looking at me incredulous and saying, how is it possible that I could develop a genetic disease at 91? And I remember, kind of laughing with her and saying, well, I guess you were lucky, that for 90 years you were, your genetic disease didn't turn on. But I think, but to your question about menopause and perimenopausal, 50s are a time for many women when they are going through that change, and we certainly know hormones play a role in psoriasis, at least to a degree. We see that in our young women. Young women, when they get pregnant, often, not always, but often their psoriasis spontaneously gets better. And so, people have explored, gee, what is it about the hormones that are present in elevated numbers? What is about those hormones that might help put psoriasis at rest? And while we haven't figured that out, one has to wonder if, when the opposite's occurring, when women's hormones fall, whether that exposes people to to something that is triggering the onset of that disease. But I think this question of how for women our hormones might interplay with turning on and off this genetic disease is not understood.
Thank you. Next question here. I know I have psoriasis and have had it for many years. My question is, how do you know if you have psoriatic arthritis?
Gee, that's a great question. The question of of when to diagnose psoriatic arthritis is often very, very tricky. It's tricky for us as physicians, and it's certainly tricky for patients. So we know that someplace in the vicinity of about a quarter of patients who have psoriasis will go on at some point to develop psoriatic arthritis. Now, even that number is not completely clear because it depends who you ask. So in my practice, where I see a lot of very sick patients with, more severe psoriasis, that number is certainly 25, 30, sometimes even higher %. In other people's practices where they're seeing people who have more limited disease, just a spot of psoriasis here or there, they don't feel that they're seeing psoriatic arthritis quite as often. So exactly how frequent it is really still up for grabs. But I think the symptoms that we tend to associate with psoriatic arthritis are stiffness. And what's very interesting or very unique, I should say, about psoriatic arthritis is that it's a type of arthritis that occurs most frequently at rest. And this is in contrast to other kinds of psoriasis. So, for example, people have rheumatoid arthritis. They might, get up feeling okay, but then as they walk around and do the activities of life, their joints slow down. They get stiff, they get sore, and as a result of all the exertion and movement of those joints. In contrast, psoriasis patients will tell me how when they wake up in the morning, it just takes them a very long time to get to loosen up to the point where they can get up and walk about. And very tellingly, they'll also tell me that if they sit down for a while, let's say they go for a long car ride or they're sitting watching TV for a while, getting going again is really difficult. So it is that's often a clue that a person's having psoriatic arthritis, but that's just a clue. And sometimes we have to put a bunch of factors together to try to figure out this diagnosis. I think, unfortunately, there's not, say, a blood test that can be done that proves it, like we have, for example, in diabetes. You know, you can take a blood test tomorrow and someone could tell you whether you have diabetes or not. With psoriatic arthritis, we're left looking for more subtle clues. So it can be challenging even for rheumatologists and dermatologists to make that diagnosis. But stiffness at rest, especially lasting for a long while in the morning, are often clues that this may be a concern.
Thank you. Next question here. Are eczema and psoriasis related? I have both.
No, they're not related. And in fact, it's interesting. Until a couple of years ago, we used to think it was completely impossible for people to have both. But, you know, that was just one of those ideas we had that wasn't true. I think I have patients like you who do have both, but they are different kinds of processes. So psoriasis is mediated by Th17 cells primarily, and eczema, in contrast, is mediated primarily by immunocytes that are called Th2 cells. So they're like going down different pathways in a supermarket. They're both skin processes, and they both can have similar symptoms sometimes, but they are different diseases. And you know, the severity of one does not at all correlate with the severity of another. And in fact, I think the reason we see them both in some people is that they're both pretty common. So therefore, you know, it's not surprising that, you know, someone could get two common problems.
Thank you. Next question here. Can psoriatic disease be brought on by toxic exposure or vaccines?
To our knowledge, toxic exposure and vaccines do not trigger psoriasis. I think we certainly know that environmental factors do play a role in psoriasis. So, for example, we know that, you know, the cold weather of the winter, you know, certainly is hard on psoriasis. A lot of patients will flare during January and February when the weather is cold and you know, and nasty. On the other hand, we also know that sunlight is beneficial for psoriasis, and so that, you know, many patients, I mean, not all, but many patients find that in their summer, their skin is a little bit better than, you know, than other times during the year. But to our knowledge, toxic exposures are not known to flare psoriasis. Now, you know, that may be a result of the fact that, you know, people don't study toxic exposures, because, of course, if you were the patient, who would want to be enrolled in that study? You know, can you imagine if I said to a bunch of patients, I'm going to expose you to something toxic just to see what happens? Of course, nobody would want to do that. That would be totally unethical. So, to our knowledge, it's not associated with flare of psoriasis. Nor is vaccination associated with flare of psoriasis. And in fact, we vaccinate our patients with more severe psoriasis prior to starting them on some of the immune suppressing therapies. So, for example, I like my patients who are taking some of these immunosuppressive therapies to get vaccinated with the flu vaccine, because there is an increased risk of infection, and I want to make sure that that they, you know, don't wind up with a bad case of the flu while we're treating. So I think, to my knowledge, neither of these are associated with flares of psoriasis, and you know, certainly when it comes to vaccines can be administered for psoriasis. If you are on one of those immunosuppressive therapies, you want to be sure to talk to your the doctor who's giving you that medication, because some of the vaccines we'd have to stop the treatment and before you could take the vaccine. It depends on the kind of vaccine. Other vaccines are fine to take just, without any interruptions. So you definitely, before you take vaccines, would want to talk to your doctor, but they don't make the psoriasis itself get worse.
Thank you. Next question here. I have moderate plaque psoriasis. I'm wondering, will the psoriasis calm down the older I get, or will it progress?
Yeah, everybody's an individual when it comes to that. So age, unfortunately, is not a panacea when it comes to psoriasis. I think, I think that for some people, for most people, how their disease starts is how their disease stays. So that if your disease is more mid-level, chances are it's going to stay more mid-level throughout your whole life. And there's always some years that it's a little bit better and some years that it's a little bit worse. But most of the time, people hover around their own middle point.
Thank you. Next question here. I notice sometimes I get a single spot on the left wrist and the same spot on the right. Is this neurologically caused by stress?
That's I think I was alluding to that earlier. It's such a conundrum. It's so quizzical why that occurs in psoriasis, but it's very common. So for example, people often get symmetric spots and we don't know why that occurs. Certainly, the skin and the brain are embryologically derived from the same tissue. And there's no question that our mood and our, for example, stress definitely makes psoriasis get worse. But why it would cause exactly matching spots on the two sides of the body, that I can't explain. But it's certainly something we've all seen, and so that it's by no means is it unusual.
Fascinating. Next question here. Are scientists any closer to discovering what all psoriasis patients physically have in common on a molecular level?
Yeah. So, there is research being done right now looking at gene banks of those who have psoriasis. The Psoriasis Foundation actually was pivotal in collecting these samples. Maybe some of the people on this call are, participated and sent in their tissues. What we're trying to understand is whether everything we call psoriasis, whether it's all the same and caused by the same single genetic abnormality, or whether in fact there are many different genetic abnormalities that we call psoriasis, but they're actually minute little separate processes. Thus far, it's starting to look like the latter may be the case. So in other words, there may be quite different genetic abnormalities that we currently call psoriasis under one umbrella term. And in due time, we may separate them. And that has fantastic potential from my perspective because, let's just label those types like A, B, and C, for example. It may be that type A will learn, which is one genetic type, would respond better to one treatment than type B might, for example. So it would be really wonderful if we could get down to that molecular level and really see what's going on and then direct our treatments very specifically to it. I think that's what they're talking about when they refer to personalized medicine. So so stay tuned. I don't think that's sci-fi at this point. I think that's probably, just in stone's reach of when we're going to start to being able to do that. But I think we may come to see, for example, that pustular psoriasis is different than plaque psoriasis, and that may be different than psoriasis, that involves, the areas, say, under the breast or in the groin, or maybe not. So we really need to understand this better. So we're just starting to now.
Great, thank you. We have time for one more question on this topic. Can you please speak to the role that emotional stress has on psoriatic disease?
Boy, I think if there's a question, probably everybody listening to this webinar tonight, probably all of you are shaking your head, because I think everybody knows that that stress contributes to psoriasis. I think what's more baffling, I think it's very common, for example, when people are going through stressful situations like a divorce or the loss of a loved one or something very pivotal like that. It's very common for psoriasis to flare. What's perplexing, though, is that I've had many a patient come and then say, my psoriasis flared when my mother died, but now I actually feel okay. Life is good. And psoriasis doesn't just turn right off. So exactly how stress interplays with turning on and off that genetic code that triggers psoriasis, we don't understand. But I very much do believe that stress is a very important piece of especially for many people, of making their disease flare.
Thank you. So we're going to now move on to questions about treatment. And first question here, are the newer drugs better than methotrexate for treating psoriasis?
Well, I would tell you that my opinion is that the drug that works is the best treatment. So, and of course, it also means the drug that not only works, but it's the drug that works and you tolerate well. So I think if a drug is working great and you're happy and you're tolerating the medication well, the grass is always greener on the other side. So don't go there. Just stay put with what you're doing. But I think, having said that, what's been very cool in the last decade or so is that we've been able to develop medications that more specifically target the immune processes that are going on in psoriasis. And before, say in the 1970s and 80s, when methotrexate and cyclosporin and those medicines were being developed, our understanding of the autoimmune process was pretty primitive and, in fact, often wrong. So as we've come to understand how the immune system works, then we can target that immune system in different ways. And that's why you're seeing this proliferation of new medications, because you can look at that immune system and say, I can block it here or there. Imagine if you were driving in a city and there was a big traffic jam. You might, if you knew your way around, you might say, you know what, I'm going to turn right here and see if I can go down the next street and bypass, the traffic jam up ahead. And in doing that, that's sort of what we're doing with biologic medications, which is we're trying to approach the disease in different places and see which place gives people the best response. So I think the newest drugs have higher PASI scores. A PASI is a way of measuring how much psoriasis responds to treatment. So in that regard, statistically, more people will respond to these newest drugs than some of our older drugs, like methotrexate, for example. But that doesn't mean that there aren't people on drugs like methotrexate who don't get home run type response from that medication. So it's certainly, I think, the important takeaway from this question, and this is a very important question, is if your psoriasis is not doing so well on a drug, then know that some of the newer drugs, might truly be much more effective for you. On the other hand, if you're doing great on the drug you're on right now, just stay put.
Great, thank you. Next question here. Do you have any tips for how to deal with psoriasis in sensitive areas, such as between the legs or in hard to reach areas like the scalp?
I think you just cut off for a second. Did you ask me about the scalp, between the legs and the scalp?
Yeah, hard to reach areas like in between the legs and the scalp. Do you have any tips?
Yeah. So I think in both of those locations, one of the problems is the rubbing that goes on. So in the scalp, it's habit. You know, many of us have the habit where we kind of scratch our scalp. And I bet, you know, many people listening tonight are kind of smiling, thinking, yeah, that's me. I think what happens is psoriasis is so itchy that it's very common for people to develop a habit of scratching their, half the time they don't even know they're doing it. And family members will say to them, you know, will you quit scratching your scalp, you know? So I think, so the thing in this with the scalp is to force yourself to break that habit, because otherwise it's like we were talking about earlier in this conversation. Um, you know, we talked about the fact that psoriasis tends to occur when the skin is traumatized. So if you keep scratching, then that keeps traumatizing the skin, and you can see where you get stuck in just a terrible vicious cycle where, you know, scalp is itchy, so you scratch it, which drives more psoriasis, which makes your scalp itchy, et cetera, et cetera. So you see that's something that's not very helpful. So I think in the scalp, the first, the most important thing is to figure out how to break that habit from that scratching habit. And then, of course, combining that with treatment so your scalp feels better is also equally important. And most of the time, the treatment in the scalp is topical things. They often can be very helpful and very effective, but not always. And, you know, there are definitely patients who I have on systemic medicine solely for their scalps. So, so sometimes if it's severe enough or persnickety enough, we do turn to even some of our most strong medications to try to address the scalp disease. I think in the inner thighs, it's sort of a variation of that same idea. I think for many of us, our thighs rub when we're walking, and then that again causes friction, which in the skin translates into trauma. So things that can prevent that rubbing are what you want to be thinking about in terms of prevention. So, for example, sometimes it's, you know, it might be just wearing clothing. So, you know, wearing pants or some kind of long underwear so that way that skin doesn't chafe, skin against skin. For other people, it may be making sure that skin is really dry. It's really easy to, kind of be toweling off and go 1, 2, 3, I must be dry, and that, you know, that area of the inner thigh often persists as being, you know, kind of damp and clammy. And when skin is wet and it chafes, then it definitely gets irritated much more readily. It may be using something like a hairdryer to intentionally dry that area more completely, or putting powder in the area so the skin slides against the opposing skin a little bit, you know, with a little less friction. I think there's no magic bullet here, and of course you have to combine it with, you know, specific treatments for the area. But I think if there's any ways to prevent friction, you know, that would be very important. And I also want to add to that answer that you know, sometimes it also means losing some weight or doing some exercise so that the skin is a little tighter and there's not as much friction. Those things are helpful as well, although obviously easier to say than to do.
Great, thank you. Next question here. If I'm on a biologic for psoriasis, will that keep me from getting psoriatic arthritis?
Oh, what a wonderful question. I wish I knew the answer to that. I think the answer to your question is we don't know yet. People have wondered about that very question, whether treating the systemic inflammation of psoriasis will prevent psoriatic arthritis. We don't know that yet. It's probably going to take another 10 years till we can amass enough information about enough people so that we can see if the incidence does indeed really go down. You know, it's also further complicated. As I was saying earlier, we're not even sure what the right percentage of people who have psoriatic arthritis exactly is. So, so stay tuned on that one. But I think, you know, I'm hopeful that the answer may be yes, because, you know, if you think about it, it's for the vast majority of patients, they develop psoriasis first. And psoriatic arthritis really doesn't come till much later, usually 10 or 15 years later. So that means that systemic inflammation has been a problem for 10 or 15 years before the joints really start getting involved. So one has to wonder if we can suppress that inflammation in the first place, then the body wouldn't have 10 or 15 years worth of inflammation going on, and that maybe that would reduce the chance of developing psoriatic arthritis. But as I said earlier, nobody really knows the answer to that question, and it is something we'd all like to know, because it would certainly make an important argument for why we have to be even more aggressive with treating psoriasis patients, as early as possible, if that were true.
Great, thank you. And next question, do I have to continue taking medicine to stop from getting the sores and blisters?
I think, unfortunately, the answer is yes. What we don't know in 2018 is how to turn off that genetic disease. I often think it's sort of like a light switch. When the light turns on, if I could just figure out how to turn it off, then, it's easy. In psoriasis, we're left with the light. When the light comes on, we're trying to throw blankets over the bulbs, hoping that, we can make the light be muted. So I think, as you can understand, if we take all those blankets away, in essence, the medications that you're taking, then there goes that bulb again. So most of us believe that for most patients, treatment, especially the systemic medications, be they the conventional ones or the newer biologic ones, that they really do require, taking that on a forever basis. Lifelong is what we're thinking at this point.
Thank you. Next question here. Sorry, one second here. Do biologics tend to lose their effectiveness over time?
Unfortunately, the answer to that question is sometimes they do. And we're busy, we as scientists are busy trying to understand that, because obviously that's dreadful. And nothing is more disappointing to a patient than having a great response and then having it slip away. That is just the most disheartening thing ever. But I think what we don't understand is what causes it. Is it coming as a result of certain properties of the drug? Is it coming as a result of the fact that maybe people aren't always as dutiful with taking the medicine as regularly as they should? We don't really understand why that can occur. And there seems to be a little variability. So, some drugs seem a little worse than others. And even though we think they're all quite similar. And so I think we don't understand what's going on. So I wouldn't begin to tell you, right now what the percentage likelihood. But I think what we see for many of our drugs is that the most extreme example is if you're on a medicine and you stop it for whatever reason. Maybe you don't think you should take it anymore, or maybe you need to have surgery, or it could just be you're no longer in the mood to take the medicine. When we try to reuse it, in about a third of patients, it seems like the drug doesn't work nearly as well. So we're very much trying to understand what is contributing to that so that we can preserve these medicines. It's been like a renaissance in the psoriasis area. We went from having almost no effective treatments to now having, such a robust number, but it's still only a finite number. And, psoriasis is a disease that occurs lifelong. So you need to keep those therapies, those treatments sort of in the bank, so to speak. I don't know about you, but I wouldn't want to be on my last one when I was 25. I'd want to think that I had enough that, that there would be treatments around and available to me really until I lived to be 100. So I think that exactly what causes people to lose efficacy is something that we as doctors are really struggling with right now. And it's not just us as dermatologists. I know I've gone to meetings and we've had these conversations with rheumatologists and with gastroenterologists because we're all using the same medicines, or many of the same medicines, and we all see many of the same issues. And we're busy trying to understand it so that we can keep drugs working for people.
Thank you. We have a question about topicals here. Is it okay to use a steroid topical treatment if I have psoriasis on 15% of my skin?
So I think when to switch from topicals to an internal medication or ultraviolet light phototherapy is really a personal one that you should really be talking about with your provider. But as a rule of thumb, what starts to happen when you have a lot of your body covered by psoriasis, and 15%, if it is that amount, is a pretty good amount. I would consider that a more severe amount of psoriasis. What tends to happen is, number one, it is so time intensive to use topicals on that much of the skin, so that I think people just don't, because it's not possible. They tend to just choose certain spots. So let's say they really don't like the spots on their hands. They might treat those areas because they show, and just say, forget about the areas on my belly because no one's going to see that. So I think the time starts to be hugely problematic. And then you have to worry about systemic absorption when you're putting medicines so extensively all over the body. And how much of a risk that is really depends on what the strength of those medicines are. If I got over-the-counter hydrocortisone, that risk is a whole lot less than if I take, say, the strongest steroid that we have available. So I think definitely, while there are always some patients who, choose not to treat their disease, even when it's extensive, with more intensive therapies. I think most people, feel that when psoriasis is more than about 10% of the body's surface area, that probably topicals are really more of a helpful adjunct rather than the prime event.
Thank you. Next question here. My plaques have cleared up, but I still have dark patches on my skin. Is there anything I can put on that to make them lighten up?
No, there's really not. There's a name for that. We call that, the medical name is called post-inflammatory hyperpigmentation. And what that word means is just where the inflammation used to be, the body put down pigment. It's very much the same process as getting a tan, only we think of a tan as being a good thing, and we don't think of the marks left over from psoriasis, that shadowing in the skin, as being a positive. Too bad we don't, because obviously that would often, as the person raising this question is suggesting, those spots, people are troubled by them. But what's really wonderful about the human body is that it has its own little scavenger system. So when the body puts down pigment in response to that inflammation, over time it sends out what are called macrophages, which are these, essentially think of them as trash collectors. It sends out those little trash collector cells to pick that pigment up from deep in the dermis and repackage it and put it right back in the epidermis where it belongs. So, and that's, quite frankly, that's why if you got a suntan, this summer, probably by now, unless you've been out in the sun lately, it's probably gone, because the body has done just that. It's taken that pigment from that tan and put it back where it belonged. So that too will happen with psoriasis. The more inflammation that was involved in that psoriasis, often the worse that pigment is. So it's deeper and darker and more prominent. But as long as you can keep the psoriasis away, that will all fade. So it's not permanent, it's not scarred, and it is, and you can be reassured that tincture of thyme will take care of it. Unfortunately, because of the depth of the pigment, it's in the dermis, which is where it is. Topical, creams like bleaching agents don't work, and so, and in fact, they make it worse, because then the top of the skin gets one color and the bottom of the skin is another color. So people wind up looking a little bit, in my opinion, like a bullseye, because they wind up with multiple colors. So I would really encourage the participants in this webinar, if you have that, rest assured that it's going to go away on its own. And the key thing is to prevent the psoriasis in the first place. So really work with your provider, with whatever therapies you're doing, to make sure the psoriasis stays quiet in that area so the skin has a chance to heal.
Thank you. And next question here. Do biologics cause irritable bowel disease or diarrhea?
So there is, first of all, let me start by saying psoriasis and inflammatory bowel disease are diseases that sometimes travel together. So in other words, they occur more frequently than you'd expect just for two independent diseases. So many people have wondered if there's not some overlap of that genetic code that's causing, that triggers both of these processes. We don't know that for sure at this point, but that's sort of speculation. So there are certain people who have psoriasis who are also predestined to get inflammatory bowel disease. And so, and that is totally independent of any treatment whatsoever. But then you add on top of it some of the different treatments. And, now that we're starting to have so many varied treatments, what we've begun to notice is that there are some medicines that we use to treat psoriasis that also treat inflammatory bowel disease. And then there are other medicines that we're using to treat psoriasis that seem like they exacerbate inflammatory bowel disease. And that's not 100% clear, but it's at least suggestive. And the biologics that seem to be raising a concern in this regard are what are called the IL-17 agents. So, the trade names for those are Cosentyx, Taltz. The generic name for that is ixekizumab. The generic name of Cosentyx is secukinumab, and then brodalumab is the third medication. So the IL-17s are the medications that, if somebody has inflammatory bowel disease, I try to stay away from those medications in those people. And certainly, and even if they have just a family history of inflammatory bowel disease, if it's at all possible, I'd probably prefer to avoid them.
Great, thank you. One last question here for treatment. You mentioned that skin often gets worse in the winter. What can I use to keep my skin moisturized to keep it from cracking?
Yeah, so, moisturizer, the biggest thing with a moisturizer is to use it. I think of it as sort of like my exercise bicycle, just because it's upstairs, doesn't mean I get any exercise. So with moisturizers, it's sort of the same thing. It really requires that discipline to apply it twice a day. What you really, especially in the colder weather, what you really want to be using is a product where the second word says cream. The brand, I'm not as fussy about. So if you like a particular brand and it says cream, then it's a good one. Lotions tend to be thinner, and for some patients with psoriasis, lotions are fine in the summer when the air tends to be a little more humid. But creams have much more oomph to them, and so therefore they work much more effectively. So if you're having trouble in the winter with dryness that's irritating your psoriasis, I definitely go with a moisturizing cream. And the other thing I'm going to tell you is keep trying a bunch of brands. I think we're all very different in our tactile sensation. So in other words, I might love brand 1 and you might love brand 2. And for me, brand 2 is all tacky and sticky and I think it would feel terrible. So, I tell my patients, buy small amounts the first time you go to the store and buy a whole bunch of them, buy 6 kinds, and then try them all out and stick with the one that when you put it on, you think, oh, this actually feels good. And when you get to that point, just, then buy it in quantity and buy it big, because basically that's the moisturizer you want to use. You want to use it twice a day, every day.
Great, thanks so much. So we're now going to move on to our final topic, and that is lifestyle questions. So first lifestyle question we have here, how much does alcohol affect plaque psoriasis?
Yeah, it's a conundrum how to understand alcohol when it comes to healthcare. We certainly have heard the reports about how, having a glass of wine every day, is good for psoriasis, or is good for your general health, I meant to say. But what we know is that problems with alcohol and drinking a lot is something that does occur more commonly in patients with psoriasis, and it does seem to correlate with more severe psoriasis. So I think I probably would say moderation is the key here. A little bit is probably not, is probably okay for most people. If you're having more than, a couple of drinks, I think that's crossed the line to being more of a problem.
Thank you. Next question here. You have studied diet has anything to do with psoriatic disease?
I'm sorry, you broke up, so ask me again.
Oh, have any studies been done to determine whether diet has anything to do with psoriasis?
Yes, there are a lot of studies that are being done, because certainly that's probably the question everybody wants to know. Is there something they're eating that is contributing to their psoriasis? So, the most common question has to do with like gluten. And certainly there are reports of people having, having a diet that has a low gluten intake, and that improving their psoriasis. But I think all in all, there is not a specific diet that we know will really be beneficial for everybody. And there is still much, much, much that needs to be done to really understand the true role of things like gluten and nightshades and all these, and the nutritional supplements and vitamins, the true role that they play in this disease.
Thank you. AARP magazine recently recommended fish oil for leg psoriasis. Is this good or bad, and does it have any side effects? Nobody really quite knows either here when it comes to fish oil. So there is, a little bit of evidence that that fish oil can reduce inflammation, but again, not good studies in the psoriasis space. So really, it's not something I can really encourage your listeners to to try. Thank you. Next question. I break open and apply vitamin D capsules directly to my psoriasis hotspots. It seems to soothe it. Is this okay to do?
So topical vitamin D is a very lipid. It's an oily type of vitamin, and certainly the vitamin D, the oil part of it is fine, and in fact, it probably moisturizes the plaques, which is probably quite helpful. There's also some topical medications that are related to vitamin D, and so we know a little bit about vitamin D from their role in treating psoriasis, and so that is something that at least is somewhat helpful in treating psoriasis. So I think there's probably is probably not harm in what your reader is asking about. There's just little known about it.
Thank you. Does turmeric help with psoriatic disease?
Yeah, I know there's stuff written about it, and I was once involved when I was at Penn in a little trial looking at turmeric to see if it was helpful. And in our study, I know it was not. I know there's certainly though is stuff written about the role of turmeric in reducing inflammation. So I think I think at this point we just not sure.
Great, thanks so much. And is there anything holistic that can help manage symptoms, such as meditation or yoga?
Oh, I think that's hugely important. So, we were talking earlier about the role of stress in psoriasis. So anything you can do, whether it be exercise or meditation, getting enough rest, eating a healthy diet, all of those things all contribute to, I believe, reducing the stress burden in a person and therefore the severity of their psoriasis. So I would strongly encourage everyone who has psoriasis to work on those kind of lifestyle healthy behaviors, so that it adds up into the it adds up in reducing stress. The other thing is that we've come to understand that psoriasis is associated with heart disease and increased risk of earlier death. And so things like exercise and eating a healthy diet, all those things are also really important in that regard as well. So for both reasons, both in terms of easing the stress and also in terms of a person's just general health and well-being, I think for all those reasons, meditation and those kind of approaches are very, very important.
All right, we have time for one final question here. Are there any cosmetics that should be avoided when I have psoriasis on my face?
Yeah, the answer to that is if the cosmetic is not irritating your skin, then it's all right. If you want to hide the psoriasis on your face, what you want to look for is a cosmetic that has a green tinge to it. Because if you remember from being in high school art classes, green and red are on opposite sides of the color wheel. So therefore, a makeup that has a little green tone to it will actually hide the redness of psoriasis better than a regular makeup would. But if a medication isn't causing irritation, then it's okay to be using in terms of your psoriasis. My favorite place to test anything, if you just say, gee, can I tolerate this or will it irritate my skin, is on the inside of your wrist. And what I recommend that you do is you put a smidgen of it on in that location. So for example, you take your makeup and you rub a little bit in the inner aspect of your wrist and go to sleep with it on at night. And in the morning, if it's not red and irritated, then odds are you're going to tolerate it on your face. Can't say that 100%, but it's a pretty good guess. So I think most of the time makeups are tolerated pretty well by those with psoriasis.
Great. Well, thank you so much for sharing all this great information and the in-depth answers. And if your question did not get answered today or you still have questions, please contact our Patient Navigation Center by phone, email, or live chat. And once you leave today's webinar, you will receive a survey on the presentation, and we'd appreciate if you would complete that and provide your feedback. And finally, I just wanted to mention the recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. Thank you, everyone, for joining us tonight, and I hope everyone has a lovely evening.